Hi, welcome. Let's talk about heart failure pharmacology. Pharmacology is essential in heart failure because medications directly target the core problems of the disease: fluid overload, poor cardiac output, and harmful compensatory mechanisms. Since heart failure has no cure, drugs are the primary way to relieve symptoms, slow progression of the disease, and prevent hospitalizations or exacerbations, as well as reduce mortality. So, most of the medications we see in heart failure includes antihypertensives, as well as those medications to improve heart contractility and slow down the heart rate. So, like I said, when the patient has a heart failure, that means the heart is not pumping properly or it's not feeling properly. So, they could be fluid overloaded. So you need to get rid of that excess fluid so that the patient can breathe better, they can be less fatigued and be able to go on with their daily life activities. Some of the ways we can reduce preload or that fluid overload is diuretics, like furosemide, very common medication. You will see it in your exam at some point. Some of the nursing considerations with diuretics like furosemide is to monitor the ins and outs. Whatever the patient is drinking or what they're peeing out, you want to measure because you need to know, are they just drinking and drinking and they're not peeing as much? So that means they're retaining that fluid. You want to check their daily weight every day, first thing in the morning after emptying the bladder. You weigh yourself before you go on with your daily activities. Lung sounds. This is important because if the patient is fluid overloaded, they'll have crackles, especially if it's a sided heart failure. Edema or bilateral feet edema on the sacrum, especially in right-sided heart failure. They are fluid overloaded. If they have ascites or they have hepatomegaly, splenomegaly, those are signs of the right-sided heart failure. So you want to monitor that. Watch for electrolyte imbalances, especially low potassium. So there's a difference between diuretics, furosemide, and ACE inhibitors and ARBs. In furosemide or diuretics like furosemide, hydrochlorothiazides, the diuretics, they make you pee all the electrolytes out. Especially, we're worried about potassium, especially with furosemide. So make sure they get their supplement. Keep an eye on that potassium level. Assess for dehydration and hypotension, dizziness, orthostatic hypotension with every type of antihypertensive. You don't teach your patients to expect increased urination when they're on diuretics. Report muscle cramps that could possibly, or muscle weakness that could possibly be low potassium. Dizziness with every antihypertensive, they might be dizzy, so that orthostatic changes. Rapid weight gain. If they do gain weight rapidly, they need to report to their doctor because that means they're fluid overloaded and it's just a matter of time before they can get worse. Avoid taking these diuretics late in the evening to prevent nocturia. What do I mean by this? We usually want to tell the patient not to take their diuretics or their furosemide, hydrochlorothiazide towards the time when they're going to sleep because these medications make you want to pee very often and this will disturb your patient's sleep as well as risk of falling at night when they are not, at their best and they're not so alert, they're tired. So they keep getting up to go to pee and they might fall. Moving on to ACE inhibitors and angiotensin receptor blockers. For these medications, they're usually put together because they're kind of like brothers, sisters. With them, usually they help to block the RAS system, which is also a compensatory mechanism in heart failure. When there's decreased perfusion to the kidney releases that renin and the cycle starts until it comes to the end where the angiotensin 2 is produced and the aldosterone. So these ACE inhibitors and ARBs block RAS system. So when that happens, this means this patient will be peeing out a lot of sodium with water so that they can reduce that fluid overload, but then they're going to be retaining potassium. So it's the opposite for diuretics. In diuretics, you lose potassium. In ACE inhibitors and ARBs, you retain potassium. So with ACE inhibitors and ARBs, you want to monitor their blood pressure, kidney function, because ACE inhibitors are very and ARBs are very strong medications and they can injure the kidney. So you have to keep up with the kidney functions. What are those labs that you need to look at with kidney function? You need to look at the BUN creatinine. If they are elevated, you are worried about the kidneys going down, or if they have decreased urine output. Like I said, check on their potassium because they're at risk of hyperkalemia. Watch for cough. Cough is really common in ACE inhibitors. And so tell your patient to report this to their provider so that they can switch them to ARBs. So most patients, when they are on ACE inhibitors and they have this, they are switched to ARBs like losartan, and then that stops. We also want to monitor for angioedema with ACE inhibitors and ARBs. This is where the patient reacts to this medication. They swell up in their mouth, their tongue swells, and their lips, and this can block the airway. Teach your patient to rise slowly to avoid dizziness. That's the orthostatic hypotension that happens with every antihypertensive medication. So we always teach our patients to rise slowly. Do not use salt substitutes high in potassium. I just said that with ACE inhibitors, you retain potassium. So go easy on salt substitutes because those kinds of substitutes are very high on potassium. So remember, we talked about compensatory mechanisms that helps the heart to kind of function better by either reducing the preload, afterload, slowing down the heart rate so it can feel, or maybe improving the contraction of the heart. So with slowing down the heart rate, we have beta blockers. And also it helps with reducing the afterload by decreasing that vasoconstriction of the arteries. So with beta blockers, we want to check their heart rate and blood pressure before giving. Pay attention, guys. You will come across a question asking you that you have this patient, their vitals are XYZ, and you're about to give metoprolol. What is the next best thing to do? If their heart rate is less than 60, you're going to hold that medication. If their blood pressure, systolic blood pressure is less than 90, you're going to hold on to that medication. You're not going to give and tell the provider. Watch for bradycardia, fatigue, or worsening heart failure symptoms because beta blockers slow down the heart. And sometimes it could slow it down so much that it's now not helping. Other patient teaching could be do not stop abruptly. We never stop antihypertensive medications abruptly. We taper down. We always reevaluate to see if the implementations that we did are working. So that includes checking if they are gaining weight or losing weight, if their fatigue is improving, they're able to do their daily life activities better, and they're able to tolerate the medication better. That's reevaluating your interventions, seeing if they work. And if you can remember which type of patients do we be careful when we give them beta blockers. There are two patients. One is patients with asthma because beta blockers can go and cause bronchospasms in asthma patients, so you want to be very careful. The second person is patients with diabetes because it can mask the signs and symptoms of hypoglycemia. Other medications that we give for patients with heart failure to kind of help them with their symptoms are medications to improve contraction, the pump itself, help it to contract better. And those are positive inotropes like digoxin, dobutamine, milrinone. Those helps to kind of improve that squeeze. So nursing considerations with inotropes, positive inotropes, is to check their pulse as well. If the heart rate is low, less than 60, you want to hold. Because with the contraction, yes, it's going to contract better, but the heart has to slow down so you can have a good squeeze. Because if it's going so fast and racing, it barely squeezes because it has to squeeze so fast and release, squeeze so fast and release. And this is not impactful. So we always want to check their pulse and for the heart rate as well as the blood pressure. Monitor for digoxin is really highly tested. So we want to monitor for digoxin toxicity, and those signs includes patients with nausea, vomiting, vision changes, or they get confused. So if patient is on digoxin and they say they have nausea or they just had a vomit episode, you want to pay attention because they could be having digoxin toxicity. Watch for potassium levels because potassium hypokalemia will put your patient at risk of digoxin toxicity. So if the potassium is very low, you are at a higher risk for digoxin toxicity. Other patient teaching could be take exactly as prescribed your medication, report nausea, yellow vision or changes in your vision, and palpitations. Just to wrap up, some of other medications that heart failure patients are given to better their life and be able to tolerate and go back to their daily life activity is a very famous medication, SGLT2 inhibitors called Jardiance or epagliflozin. With this one, usually being used, it was meant for diabetic patients, but it's because it helps you pee more sugar in your kidney through your kidney, but that also sugar also drags water with it. So we want to monitor kidney function and hydration because they can get dehydrated in the process. Watch for signs of infection because a lot of sugar is being sent to your kidneys so that it can filter it out. So too much sugar down there can also increase the risk of infection. Maintain good hygiene as well. Report urinary symptoms like UTIs and so forth. Anticoagulants. Why would you give anticoagulants to patients with heart failure? Remember, when you have a lot of stasis of blood, let's say in the heart, because the heart is enlarged, dilated, some of the blood will be sitting in there in some of the pockets. And patients who end up having dilated atrium, they can also have AFib. AFib is really high risk for clot formation and as well, and this can cause stroke and PE. So we can give anticoagulants to monitor. With anticoagulants, you want to watch out for bleeding. Review their labs if they're on patients, if they're on anticoagulants, PTT, if they are on heparin, and then if they're on warfarin or coumadin, PT-INR. Use soft toothbrush and electric razors. Report bleeding or dark stools. Okay. Some medications we avoid with patients with heart failure. We try not to give NSAIDs. NSAIDs are so harsh on the kidneys. And so we need that kidney to help us get rid of the excess fluid. So if patient is using NSAIDs, they're more likely to damage their kidney and this, then therefore, we're not going to be, any medication we give this patient with heart failure is not going to be working because the kidneys are not able to filter out the urine and clear out that excess fluid. Calcium channels blockers like verapamil, diltiazem, especially it's contraindicated in patients with reduced ejection fraction. So if the ejection fraction is reduced, especially in systolic type of heart failure, we don't want to give them calcium channel blockers like verapamil, diltiazem because it slows down the heart as well. Beta blockers in decompensated heart failure, where the patient is not able to compensate those compensatory mechanisms, sympathetic nervous system is low or not there, RAS system is not there. So that means they'll have a very slow heart rate, and so giving them beta blockers is going to make things work worse. They're gonna be bradycardic, so it's gonna work against them. So if a patient has decompensated heart failure, hold that beta blocker. Consult with your doctor, pharmacist, or whoever is in charge, or your charge nurse. That's it, guys. I hope this was helpful. This is high yield content because some of these questions are the ones you will see in pharmacology and in your exams and even in NCLEX. I hope this was helpful. If it did help you, kindly subscribe, share my channel, my content, like, comment. Just give me motivation just to know that, hey, you're watching on the other side and you're supporting. Thank you so much, and I'll see you on the next one.